Hello, this is Dr. Melissa Giglio, and I am the host of Brave Talk. Today we have a very special guest, Dr. Stephen Kurtz, who is a very special person to me, both personally and professionally. I had the joy of training with him before I was even officially a psychologist, and he has influenced so much of my work. So, welcome to the show.
It's so good to be here with our 12-hour difference.
I know, not so easy to coordinate all the time, but I'm glad you get up early and I stay up late. So today I thought this would be a great opportunity to talk about how you have built Brave Voices, how that's inspired me and my practice, and really spread that knowledge globally to lots of clinicians and so many families. So I wanted to start with how you define selective mutism in simple terms for families who are kind of new to the diagnosis or still in that not so sure suspecting phase, who might be hearing wait and see.
I think it's kind of the easiest thing to diagnose because every family I work with, their kid is a chatterbox at home, and then in public situations, the voice goes off, and some in more settings than others, and some even with, grandparents and aunts and uncles. But the first thing I wanna see is a home video, and then I know in a shared vision with the parents what we're shooting for. That's the kid I wanna bring out.
The one at home, the one who's confident, the real them. I love that. I go for that a lot too, just because I feel like parents, I think, struggle a lot of times with believing that that's what we're aiming for, even though that's what they see.
Right, and
Um,
it's so validating when we look at the video and tell them about it and share the joy of who their kid really is, without the extra baggage, yeah.
so, what are the common misconceptions that we continue to encounter with SM, and that you're still kind of, trying to disseminate that information out to the broader community?
I think the one that I come into the most is that it's willful or oppositional or purposeful, and, as you know, but your audience may not, the other half of my life is kids who are oppositional, so I know those kids really well. They're oppositional to their parents and to authority figures just doing stuff, but they certainly will talk back, and it certainly doesn't interfere at all with their relationship with kids. So it's really easy to tease out that it's not willful, it's not oppositional, and that they do access tools to get over it when we give them the right tools. That being said, as you and I know, there are a subset of kids who are oppositional, and we need to deal with that and help them be a little bit more flexible. I guess second on my hit list is that it's a result of trauma, and what I immediately share with people is trauma does terrible things. I mean, it's really sad when kids have traumatic events, but it doesn't result in them not talking all of a sudden to peers or not talking to teachers or only in public situations. So we care a lot about trauma, but SM isn't a result of that.
And
You have
third, what's
time
the third one?
time for a third one?
Yeah.
So it's very concerning. It doesn't happen all that often, but thinking that it's like autism, and it's easy to confuse because you get the flat affect, you get the poor social communication, you get the kind of odd body language stuff. If kids are uptight from S, they can kind of look like what's called stereotypies. So it's very sad when people think that this is autism, and it's very, very different.
Can I ask, like, how often are you the person who kind of alters that diagnosis and they've been misdiagnosed with autism? Like, I definitely see that in my practice from some more of the local system here, I would say. But are you encountering that a lot in the US still?
No. I would say no, but I'd say that when it happens, it can be disastrous. A young man who's now on the board of directors of the Selective Mutism Association, at age 4, his parents were told to prepare for a lifetime of being institutionalized. I mean, that could have been the worst tragedy of development that I might ever have heard of, and it was just flat out wrong.
Yep. I mean, so lucky that he was able to get an accurate diagnosis. To clarify that difference there, I find that we're getting it just from because they're being evaluated by clinicians who maybe don't have experience or lots of just awareness about selective mutism. And just like you said, if they're toddlers, we're talking 2, 3 years old and they see kind of that rigid behavior, not answering to their name, not looking at them, ignoring, playing, just by themselves. It would be very easy if you didn't do a good intake and actually, like you said, get to know the family, listen to their history, see a video of what the kids like that's, I think, the biggest difference is that the child wouldn't behave that differently at home and in other environments. If, for SM they do, autism, it's pretty consistent. You can really see that behavior consistently across those environments. Okay. So, can you tell me the essential differences, in your opinion, between SM and social anxiety disorder? Because I feel like that a lot of times has a lot of overlap, but there are clear differences between the two.
I often imagine a videotape with the sound off. If you show me a videotape of a kid on the playground who has SM but not social anxiety disorder, I wouldn't be able to tell the difference at all between their behavior and the kids who are typically developing. However, the kid who has social anxiety disorder may be on the side, maybe sitting on the bench, maybe up against the fence. At choice time during preschool, they'll be kind of frozen in the middle, bit deer in the headlights. So while we can have both, most of the kids I see don't have social anxiety disorder as well, although I understand and respect the research that shows pretty much 70% of kids who have SM will also have social anxiety disorder. But those kids have trouble anticipating that they'll be humiliated or embarrassed, and that's different than just having trouble getting the words out.
Yeah, very different. And can you share a moment in your clinical work that really illustrates how bravery grows session by session? I thought this was so just, my book is Bravery Grows. You've inspired so much of my work and helped me even grow my bravery in so many ways. But, I think helping families realize what the progression might look like, especially from one session to the next, even in the early stages, I think what's remarkable about you is how quickly you get these kids to be able to speak in front of you, to speak to you.
So as you're asking the question, I have 1,000 videotapes replaying in my mind, 1,000 channels all at once. So I'll just pick the one that's kind of standing out the most. So I meet the 6-year-old girl in my office, and with her parents out of the room in the first session, she's talking to me. This is ahead of the curve. I mean, that's very pleasant, but it's ahead of the curve. So the next week, I show up at her house. She lives in my community, and I go in the house, and not only is she not talking to me, but she's now not talking to her parent on the ground floor of their house and only whispering upstairs. So I'm there 12 minutes, maybe the shortest session on record. And I said to her, sweetheart, I came too fast. We're going to get to know each other better. So we go to my office again, build up some momentum. I come back. The next session, she's talking to me with this board game I created for her about SM. The next week, her best friend is down the hall watching us play the game, and then halfway through the session is playing the game with us. The next session, the girl, her best friend, and me take that game, and we go to the picnic table that's outside her kindergarten classroom, playing the game there. The next session, we go in the classroom and play the game there along with her brother. The next session, we're on the morning meeting rug doing a kind of fake, cute, adorable morning meeting. And halfway through the session, I have the mom and the teacher in the back of the room. And it's just that kind of steady progress just by following the guidelines and progression that we recommend. But that's not so atypical. And my favorite session with her was at the ice cream store celebrating her brave talking, and I have next year's teacher next to us with the parents at the next table. So I say to the kid, "Wouldn't it be a hoot if that lady talking to your parents is next year's teacher?" And she says, "Oh, it's not. I know who she is." And I'm thinking to myself, "I know she's your teacher." And she's talking to this lady there, and that's sort of the best case scenario about how rapid and linearly change can happen.
Love that. And I think we get to see those wonderful changes happening. And for a lot of cases, there can be those stepwise, they can get stuck somewhere. And then we just kind of, again, reassess in terms of where we are and regroup and then, try to change the trajectory a little bit with the goal always being the same, but it just might be a bit slower for some kids and super fast for others. But the goal is, again, to get there as fast
Right.
as we can.
And way back to when you were with me at NYU, that's when we sat down as a team and said, "What are our benchmarks?" Because we're seeing variability, but what's kind of like the averages of how long to talk to me in a room without the parents and then invite somebody else in, then go to another location. It was fun to make those benchmarks, and they've stood the test of time, which is kind of interesting.
Well, I love that you're bringing that up because I actually just had a training at the office before here with a family, and the child is 8 years old, and the English is a second language, but they're moving to Hong Kong and they live in Shenzhen. And of course, like similar to New York, there's a million interviews to get into school here.
Oh,
And this kid has already had a little bit of treatment with someone else. She's come to me. She had a great baseline, comes into the office, gets stuck, but she really wanted to be there, and, like, we had to call it 30 minutes in. I was like, "This isn't she's really stuck." Mom had brought the sister, and, like, that just really threw her off, the younger sister being there, so we did the next session online, speaking the whole time, answering questions, even making choices. We were really talking about what the next steps are and where they are, and, the discussion was like, well, we look at the age, we look at the severity, and we're also, looking if they've been in treatment previously too, and what that response was. And we have an added variable now of you have school interviews, and this really determines where you go. So there's a lot of pressure here, and part of these interviews is you're separated from your parent. I mean, it's not only I have to take a test because she's 8, it's also I'm expected to speak to some people, and she's so new to treatment. And for that reason, I was like, we're going to discuss medication just because I'm very forthcoming about it, and I just want you to know the options, and it's never my first go-to unless we have those variables and it's really impacting them. But, I was just thinking about you and our benchmarks. And I think even way back when it was really if a kid is truly an outlier, meaning they've gone, let's say, I think I always say 8 sessions is what I think about, which is really extended for us for a child not speaking to
absolutely.
us directly. And that would be like, okay, we really have to, this is right where we are. This is like, let's say a 4-year-old, we would say 8 sessions, this is anxiety is too high. I will say here, just because I think it's taken a while to get even the psychiatrist kind of understanding um, when to medicate, especially for the younger ones who are more severe. We sometimes extend it a bit more just because parents are on the journey for it and we're continuing to talk about it. But that decision is always hard for every parent. Very few parents, I've only had a few parents I remember back in the day in New York who were like, everybody should take Prozac. But most are they all have hesitation about medication. Nobody wants their child on medication, but I always think of what you taught me. It's like, this is the thing that's going to help them get to the end of the dock. It's not going to help them jump in, but it's going to just make it easier for them to really get the benefits of therapy. So ultimately, what our goal is that they're not on medication forever. And, we can really make some good progress, and the anxiety is just prohibiting us from getting in there to help them to feel the benefits of them growing their bravery because they just feel too anxious. So I was thinking about you on that call tonight talking about it. And of course, mom's like, well, I have to talk to dad and think about it. I'm like, okay. I'm like, we're going to talk about this again because interviews are coming. I was like, next month. And I was like, I'm good. Not that good. Just because, like, and I don't know about you, I get a lot of referrals around interview time. We have, like, interview season here in the fall, and I'm like, "This you've known about this for 9 months, and you're coming to me 2 weeks before."
I
I'm gonna
love the practice interviews. Like we'll have fake, graduate students or other staff come and take the kid away and do fake testings just to get them used to it. It's been really helpful.
It is.
Not like cheating. It's not like showing them the answers to
Oh.
the, the intelligence test items, but it's just preparing for the interaction part of it, which is really cool.
That preparing for the separation, it's trying to just get them to feel comfortable in a very awkward situation for I mean, how many 4-year-olds get taken from their parents to go talk to a stranger? Like, it's not typical. Like, so it feels stressful that, we're trying to
Yeah, what
help the
happened to
parents.
stranger danger? You know?
It's like non-exist here in Hong Kong, everyone's like, "It's so safe." I'm like, "We have to stop putting that in kids' head because the world is not safe everywhere." Okay, so talking about training clinicians, so you have really, I would say created, the adaptation and rolled it out, PCIT, parent-child interaction therapy for SM, which is really I consider to be the gold standard of how we train parents and work with parents and, how we're training more clinicians to really understand the progress in which we, go through treatment, and the benefits of it. So, in thinking of that, to you, what are really the hallmarks of a good SM therapist? Like, who do you see who gets it? Who do you see who just leans into these treatments?
The first characteristic is understanding that they have to become a reinforcer. that they themselves are going to be a really primary potent reinforcer that's going to help this kid do things that the kid doesn't realize they can actually do. And then somebody who takes every interaction as hypothesis testing, like you're going to do something in real time, in nanoseconds, you're going to evaluate, did it work? Did it not work? If it didn't work, why didn't it work? And what am I going to do as plan B? And doing all that in a nanosecond and smiling through it as if you know what you're doing when in fact you're just hypothesis testing. To me, that's the clinician who's going to do well. But at first and foremost, they have to be playful enough to become a reinforcer for the kid. Um, and when they first meet us, it's just an anxiety provoking situation. They don't know how nice we are. I know how nice I am, you know?
Yes, very much so. I do think, having giving that sense of I believe in you too, and that like I know you've got this, and I'm going to be here with you going through this. I'm here to support you through it. I think is so huge for that trust and just that connection they have. Like I have little ones who come in who still like they want to hold my hand, and like part of us being independent is like like can't keep holding your hand, but they want that closeness, right? And you're like I'm here, I'm cheering you on, but you got this, and it's that gently pushing, like, "You can do this. I wanna hear your voice from all the way over here, not next to you, feeding you the line, helping, we wanna coach you so you can do it independently."
It's also interesting because I think you are as good as anybody in terms of prompting kids to do what they can do. And at the same time, we're working with parents who inadvertently are sending a message, "I don't believe you can do this, and that's why I'm gonna step in and do it for you."
Mhm.
So, it's living in both of those worlds at the same time and inviting the parents to take the attitude, that we have, which is, it is hard, but I know you can do hard things. That's wh I'm here to watch it and celebrate it with you, and
And I think that's what's been the biggest difference with PCITSM too, is really, treatment as usual before was really about us fading in and working with the kid and then bringing the parents in. And this is really about bringing the parents in at the beginning of the journey and coaching them to be that therapist, which makes total sense since they're with their kid more often. It's also helping to kind of decrease their anxiety about their kid's anxiety and helping them know, like, this is the language I use. You're gonna hear me using this every time I greet them in the waiting room with you and when you go in the room and just, their ears perk up and telling them why we practice at home. And I don't know if you still get this, but every time we talk about, practicing at home,
why
they're
do
like,
we have to
"You talk
practice it?
to me at home all the time."
You know, it's funny when I look back on where our treatment was in, 2008, we had almost no parent training in our first intensive camp that you were involved with me. So I think the role of the parent training in treatment is what has changed probably more than anything, along the way.
Yes.
Which is ironic because I don't know if you know how PCIT started was Dr. Iberg's observation, along with some others, that the kids come into the room with us and they behave really well. Then
Yep.
we go out and meet them and all hell breaks loose. So we actually went through a parallel process, which is that we got the kids talking to us
Mhm.
and and then we had to figure out how do we get other people to do the same thing.
Yep, that's so true. In my mind, the reason I thought we didn't do it at first is because the parents' anxiety and disbelief was so high. It was almost like buy-in from them to be like, I told you they could do these amazing things, and now I'm gonna, help explain how we do it and bring you along on the exposures. Because there was almost a sense of like, they did what? They spoke to 5 people today, and you're like, yeah, we this is what we just did. They did an amazing job, and here's their prize. And the kid is just chuffed that they're like, I did great. So I think that was my thinking way back when. But now it's I wanna empower the parents.
I'm gonna out a little secret with you and whoever's listening to this. So the first time that I had the parents in camp that summer behind the big one-way mirror with me, and I lifted up the curtain, because I wanted them to see the brilliant work that the counselors were doing. It was just really bad skills, and it scared me away from just showing the counselors working with the kids. But that was just a one-off. Otherwise, we did great work.
I will say this, though, that I do think us having counselors who are not to the same level as us, who are learning too in the process, graduate students, is actually super helpful for the kids too, because not every adult they encounter is gonna wait the 5 seconds, really say like, "Oh, I didn't hear that," and do the things that we have really worked on over the years. So, you know, I think the warmth of those counselors is the biggest thing, their love of kids and the playfulness, I think is like and I tend to have, college kids who come into who are, interested in psychology because they're super playful and they just wanna, play with little kids and have a good time, and it brings this energy of like, we're having, water gun fights and doing all these fun things that they haven't been able to be loud and running around doing, and, it's really great for them, and, college kids don't care about getting dirty or wet or, like, anything, like, they're just
It's
having a good
unfortunate grandfathers don't either, so I'm still in good shape.
exactly. But no, I think that's really great. Okay, how do you see, treatment programs evolving really about, you know, going forward for SM in general? Like, what are your hopes in terms of where you see this growing?
One of the things that's intrigued me of late is being a lumper rather than a splitter. So looking at the different programs for SM and looking at the common elements, there are distinguishing features, but there's also a lot of really common elements. So I think embracing those and moving those forward and making sure parents and the public know about those common elements, I think is really important. I think we have made a good sort of menu of different ways to do SM treatment. And while it can be a little confusing at first to therapists and parents, which one do I go with? I think we have become better and we will continue to be better at presenting the menu of the different ways in which treatment can roll out. So I think that's advancing. And I think that the group programs take on so many different flavors now, and I think it's really the way to go because you're doing the individual treatment at the same time you're teaching kids how to interact with other adults and with other kids. So I hope that that continues to increase. It's hard sometimes to pull together groups of kids. It takes a lot of administrative coordination and all that, but I think it's the way to go. And I can't wait to see where things like virtual reality come into play. It has a nice track record with other things that therapists treat, but with AI tools, I think that'll become another fun aspect of our work.
I think that could be really fun. I will say that I think COVID really helped me realize that you can do remote sessions with 4-year-olds and do little social groups even online with the little kids. Again, like it's definitely putting on like, a show to keep their attention the whole time. But, just to have them talking over each other during the calls and doing things is amazing. And you can have lots of clinicians on too. So we still can have that one-to-one benefit of having different adults there while still having the kids on the call too, and they're still getting that socialization and competitiveness. I think it really just opened my eyes to that.
Do you get nervous each time you meet a new kid and each time you try and do one of these groups?
Mean for the camps or like the just putting
Well,
kids together in
every
a group?
For me, every new kid I meet, I get a little bit nervous in a good way. Every time I'm gonna go to remote, I get a little bit nervous in a good way. And I say that because parents ought to know that we get that same feeling. It's just that it drives us to move forward, not to retreat. And sharing that normative anxiety, I think, is really, really important.
I think the fact that we do the intake first and I really have a good sense of where the parents are is so important. And I always do it a separate day and where we really just have time to thoroughly go through like what the history has looked like, even having that, hindsight of like, oh, I really noticed when they were, 10 months old. And it's just helpful. And then also understanding where they are in their journey. Like so many of them have had significant anxiety. So, I had a mom in who had SM and didn't really speak until, she was 17 and going to college, like how much it impacted her. So there's so much, seeing your own difficulties and seeing your child struggle that having that space without the kid in the waiting room is so wonderful to like just give that time. And then, again, the baseline observation that you created is something we consistently do because it just gives me insight into like what they're like with their kid alone in a room and what happens when someone else comes in. And I still never like to be that stranger because I'm like, I need to protect me being the person that they're going to talk to first. And then I bring in other clinicians as soon as possible. And that's the benefit of having just the office, right? Like I have trainees who are there. But we always have in the afternoons kind of kids after one another, and we have a few small groups. So if I have a kid at 3 who's new, but doing really well really quickly, I can just have them slide into the next group and keep them for like an extra 30 minutes, and then they've already had another group exposure with kids around their age. So it flows really nicely just because, I'm the person who gets so many SM kids, so I have this benefit and I have so many therapists with me all the time. So I can gauge, what am I gonna go for today? What am I not? And then when I decide to transition them to the groups, that's really based on where we are in their treatment. But to have little kids the same age, all kind of learning to play together, having that one-on-one support, being able to do exposures, doing presentations when they come in every week about different things and, just being so excited. It's really great. I feel like we can tackle a lot of things in a group setting to build that confidence before I go to the schools.
I feel like a choreographer and a stage manager when these kids are overlapping in their sessions, and we're
Oh, very much so, very much so. It helps if the groups are further along in treatment. So, like, a lot of them will come in and, they know that by the time they're coming in the room without me getting them in the waiting room, that they come in and they're like, "Hi, Dr. Melissa." Like, even if there's, like, a hesitation, like, "Oh, no, I gotta do it." And then I don't know if you know, I have this little fairy, it looks like a little stump, and on it, it says, "Put your hand here, put your hand here, think about your worry, and when it turns from red to green, your worry will disappear," or something. So every kid, every time they come in, because it's perfect height for the little guys, they're always right away like putting their hand on it as they come in, and then
is it heat
it's
sensitive?
is it it's battery operated. So basically you touch it and like it always turns from red to green. But then if it doesn't turn on, I'm like, oh, no worries today. Like just by chance, sometimes it won't work. And I'm like, oh, no worries today. We're all good. And they're like, oh, okay. So, but they can't help but touch it every time they come in, which is really cute. Um, okay, next up, let's talk about school-based collaboration because you really have emphasized the importance of it, of getting in there. I find that especially with the preschool age kids, um, the schools still feel like, oh, just let them be, this is just normal. Don't push too hard. And that's so hard when these parents are trying to advocate and the school kind of doesn't want to be open to it. Um, I think it'd be great if you talk about how important it is for treatment to have the schools understanding of what SM is and what they can do.
Makes complete difference of how it goes if I can or cannot get into the school. Um, if schools ask me, "What do we need to do?" I tell them if I could write a blank check, here's what I want. I want me and or the parent to be able to get into the classroom when nobody else is there. So 7:45 in the morning if they come in at 8:15,
Hmm.
and 3:20 in the afternoon if they leave at 3:15. And then I wanna be able to show the teacher how we do what we do. So I have them sit in the side of the room and just observing us, and then being a very active stage manager again, inviting them to come a little bit closer, a little bit closer. Um, they do understand that they are the place they, meaning schools, understand that they're the place where kids spend the most of their time. I mean, typically 6 hours for kids even as young as 3 is not unheard of, if it's a extended day kinda thing. So, they understand their importance. I think for those who are thinking they'll just grow out of it and wishing that we wouldn't be so hardcore, if they give us time to talk it through, they usually see that we need to do something, especially when we show videos of our working with the kid, and they see that in a short period of time, we've been able to get this. So I like using videos of sessions, and I just really I try to communicate to them, I'll be the best assistant teacher they ever had. And I offer for them to talk to other schools I've been in. They never take me up on it, but I think they like the fact that I am transparent about that.
Yeah, I think a lot of the concern is that we're going to interrupt the flow of their classroom or possibly be judgmental or critical of what they're doing, as opposed to our goal is really to be supportive and to help this child, to be that, signal of like, okay, I'm here. That means that when we're together, you do a lot of talking. And, that could be what really helps them to feel, number one, safe and supported, but also to say, like, oh, she always makes me have to talk. And that's, the motivation, for, to earn the rewards and that they can do it and that we'll take it slow. And, I really follow the rule of like, we'll never do more than, until you're ready. Like later we might do some surprises, but if this is the plan, we stick to the plan and that's the trust. And I think kids really respond well to that. But I feel like for the teachers to know that I'm there to really support the kid and I really try to give good feedback afterwards with lots of praise for them. Um, just to kind of reinforce that, like, I don't want to be a disruption. That's the last thing. I want to kind of blend and support as subtly as possible. And sometimes it's really about normalizing that the kid does speak, like helping to kind of set the record straight in the classroom for the other kids. Cause they always, as young as they can, they'll come up and they'll say, why doesn't she talk? Why aren't they doing that? And I'm like, oh, they talk all the time. They're just not ready yet. And that's all it really takes is someone to kind of just shut it down a bit to be like, no, they do that all the time. And then they see them doing it and they're like, oh, they do. And they're so excited. Even if it's low and just to me, it takes that stigma away that that they're this kid who doesn't speak all the time. The fear of that kind of can go away.
I think when you and I shut it down, we do with a big smile on our faces.
Yes.
Wow. I remember, this training video I have where I say to the 2 of the kids, "I didn't ask you, I asked him."
Oh,
It's
yeah.
only and it's only because I already had a relationship being around those kids that I can get away with being that blunt about it. I remember the first time I went to Dubai to treat a kid, and I live in New York. I'm on the big gym floor with all the kids, and, the girl taps me on the shoulder and says, "She doesn't talk." I said, "What do you mean she doesn't talk? She just told me what she had for breakfast and where we have to go after the assembly. Of course she talks." So it
It
can
just
be
helps
that
them to know
that
that.
matter of fact and that fun, but it is important to, uh, debunk this expectation.
And I think it also gives the kid the expectation that they can speak there too, right? That's the other piece of it. So
Sure. I know that you know that I know that you know that she actually does speak in this situation.
exactly, exactly. Okay, so what's one piece of advice that you would give to parents who are just starting this journey, who are feeling like, now what?
Well,
Like
I'll tell
something
you the
feels off.
yeah. The one piece of advice I always give, and it's very concrete, so I don't know if you want something philosophical, I'm gonna give you concrete. The free online learning course at www.selectivemutismlearning.org. Melissa,
Yes,
that course was started in 2015. Just I won't bore you with how it got started, but, we've had over 19,000 people sign up for this course, and it's free. It always has been, it always will be.
love it.
It's the best starting point because it has not only us explaining in detail step by step what we do, but it has video exemplars. It has some quizzes so people can kind of do a self-check if they're getting it or not. If they get it, they take the quiz again until they get it. So that's my most concrete advice is, start
Fantastic
with that learning.
advice. It's a great resource. I feel like we're still trying to get people to use it consistently. And I even find I'm still having to tell people, like, there's a selective mutism association out there. And like, there's just so much information online. Like, it doesn't always lead you right to where you need to go. And, um, all of that it can be really hard to navigate and you're so worried about your kid and you're not quite sure what to do. But that is a very useful, great first step in terms of kind of dipping your toe into like, all right, what do I have to get ready for? What do I need to know? And I think it really reaffirms that, yep, this is exactly what they're really struggling with. And, hopefully begin to have some exposure to the skills. Can I ask, what do you think is one of the hardest things for the parents in terms of the skill acquisition at first? Because we've trained lots of people in it and they get it ultimately with the coaching, but it's not always so easy to be consistent for parents at first. And I want to normalize that for parents that like it's you're doing a lot of things every day with your kids. It's hard to be on at 100% all the time and we don't expect that. But I do feel like sometimes even though we're going over it, it's still harder for them to really understand the little moments of what they're doing that are not hindering, but they're not helping them make as much progress as they could be with the practice and the skills.
So I'm picturing like Family Feud, how the audience would respond. The number one answer would be difficulty of not asking questions to the child in front of other people before the
Yeah.
child is ready.
Okay.
I I think that's the single most common thing. So I understand it's a leap of faith that only by praising what's praisable describing what's describable and reflecting what's reflectable, that somehow that's going to be helpful. And avoiding, in the short term, avoiding any prompts to speak is a hard thing to do. So that would be the hardest single thing to do in the beginning. Um,
I wanna ask you about what about those cases where we have those kids who have SM, but in order to just appease their parents sometimes, they will say whatever it is that time, like the goodbye and all that. So, like, that I always get, but they already we've been practicing that so much. They will say bye to that guard every day, and I'm like and so I always think of you and the percentage in your mind. So what do you say to that?
I'm not sure where you're going with them. What are you thinking?
So parents are asking so they're so we tell them not to ask any questions or not to give them any direct commands to speak to other people until we could reliably say we can get them unstuck in practice, especially right in the beginning. But we have parents who've obviously been trying stuff themselves. And some of the kids just to appease their parents will do one thing, like, and it won't be the way, maybe they'll be like, bye, and they'll do it. And the parents are like, can we keep doing that? And I'm always and so I usually say, if you can say reliably 90% of the time that child can do it, you can keep doing that one thing, but there's nothing else in terms of the hellos and do you wanna say bye? Do you wanna say thank you? But
I
some
would
kids will do just enough to be like, "Leave me alone."
I agree. For the subset of parents who are concerned about manners, I always ask the same question. I say to them, "Are you rude?" And they look at me with this quirky face, like, "What do you mean? Am I rude? Of course I'm not rude." But they don't say, "Of course I'm not rude." They say, "No." I say, "Well, trust. After we get this baggage out of the way, they'll mimic exactly the same kind of manners and good graces that you have, and it always comes to pass."
It really does. I find that, and it's always the first thing everyone wants to go to because it and I totally can see it from their perspective of like, "Oh, this feels like it shouldn't be too hard. It's just saying hi, or it's just saying bye or thank you." And we know that the initial interaction is actually when the anxiety is as highest. So that does feel that hard. Whereas, answering a question later after they've warmed up and is there's a higher likelihood they'll be able to do it in front of a person or maybe to that person if they've been in treatment for a bit. So I always feel like they really want that because they I think for them that gives them anxiety that their kid is really standing out that they're unable to do that greeting at first.
Well, I think unfortunately, it is made worse by their expectation that they're being judged as good parents if
Yeah.
their kids are polite and being judged as not good parents if their kids are somehow being perceived as rude. And, there are obviously cultural differences. So, where you live in Hong Kong, there are a lot of cultural expectations about how children are around adults. Where I am in some of the more pressurized private schools here in New York, there's expectations because the headmistress is standing there as she does every morning, extending her hand and, the bow and the curtsy and the ma'am uh, and we'll get
All
there. Yeah, we'll get there.
I think that's the biggest thing is they're just not there yet. Um, yeah, we
Melissa,
definitely
I tell almost everybody I work with that your favorite word in my vocabulary was the word yet. You and
I
I
love
have a special appreciation for that word.
I think it gives hope. I think it's just giving time and hope and expectations, and it's not, like, altering the dream. It's like, it just is gonna take a while to get there, and I love the idea of that, and, yeah, just the stages and phases we go through.
Well, you and I are also very purposeful about anything that we're avoiding today. It's going on a list of things we're going to come back to, and it wouldn't be a complete treatment if we don't.
Yep, I totally agree. Oh, well, thank you so much. I love having you on here. This is such a pleasure. You've inspired my work so much. And just even me thinking outside the box with, the children's book and the journal, just trying to like think of how we can get more information to families out there and help them. It's so hard to find, I think, the specialists everywhere. And I don't know about you, I've had like a recent influx of toddlers basically like just very recently I've had a slew of
I,
2
I
and
like
3 year olds.
getting younger. Yeah, I like
I
getting
love
them.
getting them younger, but, like, they kinda come in waves, the certain ages, like, I just before that was having a slew of, like, 9 and 10 and 11-year-olds, which I usually don't get them that old, so, like, they're just coming in these little batches, but, some of them look like babies. But, my go-to, and this is something I think is really interesting, is, we tend to see, typically there you kids are diagnosed around 3, 4, 5, typically just 4, 5, 6, right, for a referral. We do see more kids, I'd say, at 3 in general, 3, 4, because before the interviews, but the 2-year-olds we're getting, for me to know that this is appropriate at this moment for me to be able to work with them, besides just training the parent, is how much language do they have already too? And it's really, these kids tend to be super chatterboxes, even between the ages of 2 and 3, where they're just, "Ah," and you see that contrast when they go to school. Like it is already there. It's there. They're there every day, like you said. And even though they seem young, there is a massive difference. So why wait till they're 3.5? Like, they're only getting better at not talking, they're still feeling stressed every day, and they're missing out on the play and the fun in
Yeah.
preschool.
A 2-year-old is practicing 50 to 100 times a day, avoiding something. And in a week, that's several hundred. In a month, that's several thousand. It's a lot of opportunities to practice avoidance.
And when they come in even at that age and say, "I'm shy," because every adult who interacts with them, who's, like, talking to them, says, "Oh, don't be shy." I'm like, "How do I undo all that too?"
So we have our three-letter words in addition to the four-letter words.
You're so funny. Thank you so much for being on here. It's been such a pleasure to have you on. This is just something I've really wanted to do, and I'm excited that you are one of the first guests.
Thank you, Melissa.